Thank you, Hani. Okay, so my presentation is about intravascular imaging in special situations. I have no disclosure. I'll present two cases. The first case is 60-year-old lady, ischemic heart disease, status post CompEdge with Lima to LAD and vein graft to OM, done in April 2023. Presented to one of my colleagues in May 2024 and admitted as non-STEMI. That means a year after the CompEdge. He did angiogram for the patient, and this is the native angio. You can see that LAD is occluded with patent Lima. I didn't bring the Lima picture, but it was patent. And we have here also ostial circ tight lesion with calcified nodule, seems to be another lesion here in mid-circ, and also an OM, or if you want to call it PLV, with some flow back into the vein graft. And they document that the vein graft was occluded to OM. The RCA wasn't grafted, and as you can see, there is a lesion in the mid and distal and also ostial PDA. At that time, he decided to do PCI to the RCA and circ. And this is the final result with him. He started with the RCA, excellent result, except the PDA, tight lesion. He left that for medical therapy at that time. And this is the left system. He started actually the PCI from the ostial circ down to this OM, and we can see that there is still some stent under expansion due to the calcified nodule. And in his note, he mentioned that I did my best with post dilation, but this is the best, and it was acceptable. So he ended at this stage. In the note, it's mentioned that at the end of the procedure, I noticed a dissection at the left main ostium, so I stent that. But I couldn't find any picture for the ostial left main dissection. Maybe it was just a fluoro, and he didn't save that, and he did just a PCI. And then after this picture, I found the picture after the left main stenting. So he put a stent at the ostial left main. So this is the final picture for the left system. The patient discharged home and came back after 7 days exactly with chest pain, no new ECG changes, troponin or high sensitivity troponin at 82. The patient having chest pain, uncontrolled, started on nitroglycerin infusion. I was actually covering the cath lab in the morning, so they contacted me because the patient having continuous chest pain while on nitroglycerin. So we brought the patient to cath and we did angio. This is the right system, almost the same as 1 week ago, except that ostial circ, as we know that it's tight from the beginning. The left system, TIMI3 flow, stent on the ostial left main circ, looks okay. And even another projection for the left system. Do you notice anything here? Do we need to do something, or that's it? Just we have to end. Yeah.
Ostial PDA. You revascularize the right coronary for what?
Sorry.
You open the right coronary for what?
Exactly. So, but yeah, he mentioned that he will leave it.
You open it for the distal line.
Yeah.
Thank
so
you for
you think maybe the ostial PDA to just balloon it, maybe drug-coated balloon, and that's it?
Let's just continue with the presentations. We'll leave the comments shortly. Mognee, go ahead, please.
Yeah.
Thanks.
Yeah. Okay. So at that time, actually, I feel that there is maybe a haziness here in the left main, and even we can see it here, but I wasn't quite sure, so I said I have to image. So I did OCT. And this is the OCT run. This is a guide. Then we will see the ostial left main looks okay. Oops, there's something here. This is the ostial circ, looks, there is some under expansion in the proximal gap, another stent. So you notice that there is something after the left main. It's back now. So I'll stop here and they'll move it. So my guide actually within the stent of the left main, and we can see that the left main stent maybe started at the ostium, which looks good, but here we have dissection. And we have very clear dissection, deep dissection, include about half of the left main. Actually, at that time, they didn't cover the whole left main. They just stopped at the ostium. So in my mind, it came two possibilities. Either the dissection was really at the ostium, they put the stent, they covered that dissection, but then with optimization, they did distal edge dissection, but they didn't image at the end of the procedure, so they ended with this dissection. They didn't notice that. Or actually, the dissection was at the distal left main. Maybe the guide was very deep. They noticed that, so they pulled the guide, they put the stent at the ostium, which was actually normal, not dissected, and they didn't cover the real dissection. So both possibility there. And then we have here, as you can see, my wire, my catheter in the false lumen, and here the true lumen actually collapsed. We'll move. Here we have some white thrombus. And here we'll continue. Another white thrombus, and back to the ostial circ. Another white thrombus, and then calcified nodule, as you can see, at the ostial circ. So just to go back to the angio at the end of their procedure, if you notice that, maybe you noticed that, you have feeling that this is not normal, actually, at the distal left main. This is the final picture during their procedure. So actually, the dissection was there since the beginning. And I did actually sizing, I put a stent. We know that my stent will be just, half of it will be at the adventitia directly. So I went just with the gentle post-dilation with the 4.0 stent. Still I have under expansion here. It's about 60%. I'll stop, I'll go back to the area of interest. Here, you can see that part of the stent behind it, there is a true lumen actually, here. And the stent, it's not well expanded or opposed. So I went back with the 4.0, a high pressure 2022. I re-image, and this is the final. It will come. Oh, okay. So it's better expansion, more than 80%. And most of it, it's 90%. We have some artifact here, actually, because the prolapse of the catheter in the ostium, it's not moving well, but we'll try here. So because the prolapse of the catheter at the ostium of the circ. This is the final picture. The patient went home asymptomatic. I reviewed the chart. I found the patient came in July to her MRP, just complaining of exertion shortness of breath, class 2, and he ordered nuclear scan. So the lesson from this case, actually, no left main PCI without imaging. If they did imaging at that time, they would recognize the dissection and they will not leave it. Okay, case number 2, 46-year-old lady, medically free, only smoker. Admitted in June 30 this year as acute coronary syndrome in another center, chest pain, normal ECG, high sensitivity troponin 170, echo normal. The patient they did for the patient coronary angiogram. They diagnosed the patient as coronary spasm, and they discharged the patient on azorbate dinitrate and verapamil. The patient had frequent presentation to emergency room, to the clinic, different hospital with chest pain, and all they mentioned that it's spasm according to the angio. They just adjust the medication, increase the azorbate dinitrate, and change the verapamil from short-acting to long-acting. She visited different hospital and then ended to my clinic in one of the private hospital. And she said that I fed up, I need a solution for that. I have symptoms for now 1 month. She presented to me in first week of August, that means more than a month from the angiogram. So what to do now? They mentioned in the report, actually, it's a spasm. I don't have angio at that time. So either to do CT or just to do angio. But I asked her actually to bring the previous angio and to review the angio. And she brought the CT, the angio done in the other center, and this is the angio. Actually, in the CD, only 3 pictures, one for the RCA, which was totally normal, and the 2 pictures, one caudal, one cranial for the left system. As we can see that there is a tight lesion here at the ostium, and also here, no backflow, and there is actually a plaque maybe in the mid or proximal LAD. If you compare it to this, definitely there is something in the LAD. I couldn't find any picture that proved that it was a spasm. Maybe they gave a nitro, I'm not sure. At that time, I don't know what to do, either to repeat the angiogram, get a better picture, or just to do CT and to document that there is no plaque at the ostium. But I prefer to go for angiogram also because the patient really having symptoms, real symptoms. With minimal exertion, there is chest pain. Just even if it is spasm in the ostium of the left main, I will do physiology, maybe assessment for the proximal LAD. So the patient in the beginning was reluctant for repeating of angio, but then she agreed, and this is my angio. This is the first picture. And we see it's real lesion maybe. There at the ostium, you can see the haziness. There was a damping. There is no backflow. I actually did a cranial non-selective after I gave 600 of nitroglycerin. And we can see that the ostial left main is not normal. So in my mind came 2 differential diagnoses, either SCAD, but now it's almost 6 weeks after the first angio. So unlikely, usually SCAD, it should be healed by this time. The second possibility, it's a plaque, real plaque. Yeah, it's, the patient is young, 46, no risk factor except smoking, but it could be. So then what to do? Just to send for surgery, do stenting, it's ostial left main, or to do imaging just to confirm. Okay,
so you'd like to ask the audience what they would do next, right?
Sorry?
You're asking the audience what they want to do next?
Yeah, so.
Right, Doctor, what would you like to do? Anybody there who doesn't want to image this? Fawaz.
So I'll go with the guide, pass a wire, get an IVUS, document the osteal significant disease, stent it, and say no more pain should be after that.
Dr. Adil, why not OCT? Why IVUS?
First of all, I'll give a lot of nitro just to be sure that this is not spasm again, and it's unlikely to be spasm. But usually in ostial left main, we don't prefer OCT because, the guided engage and the contrast will not obsessify the ostium part of the left main. So usually the standard is IVUS. If I want to confirm in this case, maybe I'll go with IVUS.
Okay, so this is what actually done. I did an IVUS. I use actually JL3O, a short guide just to be away. And you can see that we're coming to the proximal LAD. There will be a plaque, as you can see, from 12 to 6 o'clock. So it was a plaque that in the proximal LAD, and there is something here. We are back to the left main. This is a wire from the circ coming, and this is the ostial left main. Let it run again. Coming a plaque in the proximal LAD. Now it will come from 12 to 6, as you can see this area. And maybe you notice also something now coming in here. I'll make it a still image so it may be more clear. Just concentrate in this area. Definitely this area, it's different than the lumen. So it's hypoechoic area. What are the differential diagnoses it could be? Yeah,
So
anything?
Mognee, how did you know, because Fawaz is doubting what you're saying, how did you know that this is not just an artifact shadow that where you put your arc?
So number one, the wire, actually. The wire, it's in the center of the image, which is most likely there is something pushing it. If the wire actually at the wall and there is an area which may be an artifact, I will accept that as artifact.
Exactly. So the wire was a great clue, right? Because it's just hugging that wall.
Exactly. Yep. So definitely there is a plaque which is hypoechoic. Differential diagnosis would be maybe hematoma, which is unlikely. Usually hematoma, it could be, usually it will be a hyperechoic unless there is a connection between true and false lumen with a flushing of contrast or saline. You will have it hypoechoic, or it's a high lipid burden with necrotic core. So this is a vulnerable plaque, actually. And the patient lived actually for a month without aspirin, without statin, only isorbit and verapamil. So at that time, I stopped and I give the patient both option, CABG, PCI. The patient referred and seen by the surgeon, but the patient preferred PCI. I brought the patient in the next day. I have the sizing from the first IVUS. We went for ostial left main. Good result, and we did IVUS after that. Actually, we can see that the proximal LAD, yeah, there is a plaque, but I feel that it's maybe borderline. I leave that for reassessment as outpatient if the patient is still symptomatic. And this is the IVUS. You can see the edge of the stent, nice, no dissection, and will oppose expanded stent back to the left main ostium. I went again with the 4-5 balloon just to flare the ostium. So the lesson from this case, challenge the diagnosis. Even if it is mentioned that in the report it's spasm, you have to confirm that. Give natro, do imaging. Even if the patient is young, no risk factor, she might have a such plaque, high vulnerable plaque. So take-home message also, the coronary angiography is a gold standard to diagnose coronary artery disease, but still it's considered as a luminogram. Intracoronary imaging will help you to understand the lesion, prepare it, plan, and optimize the PCI. Thank you.